Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for September 18th, 2024. Thank you for joining us this month. And thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn series. Our presenter today is Daniel Kenta White. Dr. White is an associate professor in the Department of Physical Therapy at the University of Delaware. He is the director of the Delaware ACTIVE Lab, which is focused on the study of free living behaviors in the home and community environment and how these behaviors benefit health. The goal of the lab is to develop clinically feasible and practical ways to increase physical activity in older adults and those with arthritis. Dr. White is an associate editor for Arthritis Care and Research and an active member in the American Physical Therapy Association and the Association of Rheumatology Professionals. The title of his presentation today is What We Know and Do Not Know About Physical Activity in Knee OA. Welcome, Dr. White.
Great. Thanks so much for that introduction, Katie. I appreciate it. And I'd like to thank the OAAA Action Alliance for inviting me to come and give a talk on something I am very interested in. So I very much appreciate it. Let me get these slides going. So just kind of an outline of my talk. I'd like to start by defining what physical activity and sedentary behavior are, talk about the guidelines and what the benefits of physical activity are, talk about the negative effects of sedentary behavior, and then talk a little bit about the evidence and myths around increasing physical activity. Then at the end, I'd like to just touch on some of the things that we don't know, such as how best to increase physical activity, how much sitting is too much, and should goals be performance-based or based on participation. So starting with definitions, so physical activity is defined as any bodily movement produced by skeletal muscles that results in energy expenditure. And a specific, and for an example of this is this is a picture from a park that's nearby my house called Longwood Gardens, and it's just this beautiful park where people come and they walk around admiring the beautiful plants and seeing the sort of the horticulture that is found there. And these people who come are in fact participating in physical activity. They're having bodily movement that is produced by skeletal muscles that results in energy expenditure. But in fact, what they're doing is they're looking at the plants and enjoying the gardens. But as part of that, this is physical activity. And it's important to make this distinction because exercise, which is defined as being planned, structured, and repetitive, is a specific type of a physical activity, but it doesn't incorporate all types of physical activity. So here's a picture of somebody at my gym working out and works out every morning. And this is a type of physical activity, again, that is planned, structured, and repetitive. And it's important to understand this distinction, mainly because of the studies I want to talk about. Some talk about physical activity, others talk about exercise, and just knowing the difference between the two of these are important as we move forward. All right, so another definition is that's important to talk about is sedentary behavior. So, and this is defined formally as low energy expenditure while sitting or reclining during waking hours. And most of the sedentary behavior is sitting. So there's a picture of my lab here at the University of Delaware. And if you look through, can you identify which participant or lab member is displaying sedentary behavior? Now, some of you might have identified my former postdoc, Jason Chiquila, and he, in fact, is reclining, and that is sedentary behavior. Now, Tom Bai is my PhD student, and he is squatting, but not technically doing sedentary behavior. And specifically, he wouldn't qualify as having low energy expenditure. And this is important to define, namely because there are a lot of negative health outcomes associated with sedentary behavior or sitting. And again, there's this very specific definition for this. So I just wanted to make people aware of this as we move forward with the literature. The next point I'd like to make are that exercise and sitting are mutually exclusive. So here's a little Venn diagram, and they are separate entities. So not enough exercise is distinct from sitting too much. So for instance, you can work out in the morning. So here's another picture from a gym mate, and exercise. But then you can spend the rest of the day sitting, as many of you might do anyways at work, sitting at a desk. And you can certainly have high levels of exercise, but then also have high levels of sitting. And the two are mutually important or mutually exclusive. Now, when it comes to what are we recommended to do from a physical activity guidelines perspective, well, this includes 150 minutes of moderate intensity activities, strength training 2 times a week, and then a sort of vague sit less is recommended by the physical activity guidelines for Americans. So when it comes to how much activity do we do as a society, using a population-based study in Haynes, the most recent data said about a third of Americans, a little over a third of Americans, meet the aerobic component of the physical activity guidelines. So this was the 150 minutes of moderate intensity activity. But this number of people meeting the guidelines came from a questionnaire. And it's important to recognize that when you actually monitor somebody, the amount of physical activity they do can differ from what they self-report. So when we put monitors on people and say, well, how much are they actually doing? Only less than 10% of Americans meet guidelines. And this is from a study that was a little over a decade old. Now, how about people with knee osteoarthritis, which is the population of interest that I'm interested in studying? This is similarly low, with 12.9% of men and 7.7% of women meeting the aerobic component of the 150 minutes of physical activity guidelines. Now, this is problematic with so few people meeting physical activity guidelines because for the most recent ACR Arthritis Foundation OA treatment recommendations, exercise and physical activity are strongly recommended, meaning that the benefits outweigh the harm. And with so few people with OA meeting guidelines, this is a definite gap in our management for people with osteoarthritis. Now, why is it important for people with osteoarthritis to be active? Well, there are many benefits, specifically having reduced pain, improved physical function, and there's less risks of activities of daily living disability. Also, more recent evidence has shown that reducing sitting is important for people with knee osteoarthritis. There are negative effects of sitting that include having higher prevalence of hypertension, worse pain and functional limitation, and lower health-related quality of life. Now, it's important to recognize that the negative effects of sitting are rather dependent on how active you are. So there's a group in Europe that has studied this among many population-based studies, and they found that those people who exercise between 60 to 70, those people who had physical activity between 60 to 75 minutes a day at a moderate to vigorous intensity basically had no risk of a mortality based on their sitting. So in other words, this level of activity, so an hour to an hour and 15 minutes a day of moderate intensity activity, eliminated the risk of mortality from sitting. Now, the problem with this for knee OA is that first, getting this level of activity is really not realistic for many of our patients, as well as in our studies we've done in my lab, we've only found that moderate activity is what matters for physical function, that people with moderate activity had less risk of developing functional limitation, and sitting really wasn't related to functional limitation for people with knee OA. Now, what are different methods to increase physical activity? Well, the literature shows that having apps on your phone and wearables, such as Fitbit monitors, are definitely effective with increasing physical activity. And this is a recent meta-analysis that shows that. I'd also like to highlight that motivational interviewing, which is a sort of psychological technique to reduce apathy in reaching behavioral change, when applied to physical activity, has been shown to increase physical activity as well. Now, from a knee OA perspective, total knee replacements are quite common, and the literature has actually shown that physical activity does not increase following a total knee replacement when objectively measured. So that is how much energy expenditure people have pre and after surgery. This does not change. I would like to make a distinction, though. A recent study did show that participation in sports and recreational activities did increase after total knee replacement. So, for instance, people who say, well, I want to go skiing again, or I want to resume bowling, that in fact, that this did increase. But in terms of actual energy expenditure on a daily basis, a total knee replacement does not change that level of activity. All right, so now I'd like to sort of conclude with what we know with several myths about physical activity. And this comes from Daniel Lieberman, who's an anthropologist, who is a Harvard professor and has studied prehistoric societies and modern day hunter-gatherers. And he has this book called Exercise, which essentially goes over the benefits of exercise and physical activity, but then visits some of the myths that we might have with physical activity. And the first myth that he talks about is that humans are naturally active. And this comes from a philosopher that postulated that our modern day physical activity is corrupted by the conveniences of modern civilization, such as having more having desk jobs and not having to go hunt for our food. And while it is true that levels of moderate intensity activity have decreased over time, with more jobs being more desk jobs and being less active, their data collected from modern day hunter-gatherers has shown that these sort of societies that live in the modern day, but in prehistoric or in sort of non-modernized environments, have as much inactivity as we have in sort of Western societies. In other words, both groups are inactive. And the thought behind this is that our biology is really set to conserve energy. And with that, we are not naturally active, but we do as much as we need to. In modern day hunter-gatherers, they weren't just running around to run around. They ran around and caught their food or farmed. But that really is not that much different than what we are, how much activity we have in the modern day. So that's one myth. And the other myth that is really relevant to people with knee osteoarthritis is that there's a thought that, once we remove pain and functional limitation from people with a knee OA, that people will become active. In other words, that pain and functional limitations are the reason people with knee OA are inactive. But this is actually a myth, and a former postdoctoral fellow who's now a faculty member at UNC Chapel Hill, Luis Toma, has found that when comparing data from the population-based studies to a large OA cohort, that physical activity was very similar between these groups. So the graph on the right, on the y-axis, shows the minutes a day spent in moderate intensity activity. And on the x-axis are different age groups. And on the circle represents people with asymptomatic knee OA from the OA cohort, and the square represents people from the general population. And in general, within these age strata, they were very similar between people with and without OA. So that, paired with the fact that physical activity really doesn't change prior to or after total knee replacement, really sort of debunks the myth that pain and functional limitation are a major reason why people with knee OA are inactive. Okay, so that kind of concludes the sort of points about what we know about physical activity. And I'd just like to touch on a couple things that we don't know. So the first is, we have many resources with increasing physical activity, but there's very few trends in clinical practice that are used to best increase physical activities. In other words, we don't have real consensus on what is the best method to increase physical activity. There are a lot of healthcare provider resources from existing physical activity programs, and I encourage you to look at the Elizabeth Fallon reference here that I'll share with you at the end of this talk, that lists a number of arthritis specific intervention programs to increase physical activity. We have monitors to increase physical activity, and then we also have affordable gyms like Planet Fitness. But in terms of clinical practice, we don't know, which of these to recommend. And in fact, many providers don't talk about physical activity to begin with. So this is a sort of something we are not sure with how to best combat. Another thing we don't know about physical activity is how much sitting is too much sitting. Certainly sitting is a natural part of our daily being and what we do. And some amount of sitting is fine, but we're not sure how much, at what point does it get to be too much, and it is formally defined as being excessive. Another thing we're unsure of is, should goals be based on energy expenditure or participation? So here's a fun photo of my lab, and we at ORSI a couple years ago, and we bumped into Steve Messier, who's a championship bowler apparently, but he didn't tell us this until we formed our teams and we had a bowling competition at ORSI. Anyways, the point being here that there's energy expenditure and physical activity through the activity of bowling, and should we be prescribing activities based on participation, such as bowling or dancing, or going out with friends to our patients, rather than giving them energy expenditure goals, such as, here's how many steps you need to walk, or how much time you need to spend in moderate to vigorous intensity physical activity. So this is sort of an unknown. And then the last thing I'd just like to touch on really briefly is that Martin England and others have brought up the sort of research limitations with exercise intervention studies, that being, it's really hard to have a true placebo for exercise studies. And also, it's hard to blind participants to an exercise group versus a placebo group. So when it comes to looking at the efficacy of exercise interventions, we have to acknowledge that this comes from the lens of there not being randomized, double-blinded, placebo-controlled trials. I think the consequence of this is more of a minor note than a major note, But in fact, it's important, I think, scientifically for us to recognize that the exact mechanisms of of how exercise works to improve pain and increase physical function is another big area that I see Kara Costello's on here, and others are very interested in looking at, and it is an area that we really are unsure of the exact mechanisms of how exercise works. So with that, I'd like to give a QR code for the references. This will be on the final slide too, but if you would like to access the references, please use this QR code to access a Google Doc. With that, I'd like to acknowledge the following funding sources and my lab for all the hard work that they do. And this is a QR code for our lab website. I would like to open it up to questions.
Wonderful. Thank you so much for that presentation, Dr. White. There were so many take-home points, among which who knew that Dr. Messier was a champion bowler. Um, and this was obviously a topic of great interest for the OA Action Alliance audience. I was telling Dr. White ahead of time that we had a record attendance or registration today. So Dr. White, we really appreciate your expertise and this fantastic presentation, and we will open it up to any questions. So if you have a question, feel free to type it into the chat and I will read it aloud for discussion. A couple questions related to specific forms of exercise, Dr. White, just to get us started here. Would you say that the current guidance still stands that exercise should be low impact for adults with knee and hip osteoarthritis?
Yeah, there are no specific guidelines on impact, though given the OA is really mechanically driven from overloading, that most people find lower impact exercises to be more tolerable. Um, um, so biking rather than running is preferred, but again I do default more anecdotally to the slide where I talk about participation versus energy expenditure. And some people really love to do certain activities that are higher impact, and that is their physical activity, and it's really hard to switch them off of that. So I sort of um, really defer to that participation. If that's something that people love to do, trying to continue that as much as possible is really important for me to recommend to patients.
And so a follow-up question to that, which I think you might have just touched on, but walking is considered a low impact activity, but what if walking is painful for someone? Should they continue doing that? Or
Yeah,
should walking if someone is walking and they have pain, should they continue walking?
yeah, no, that is a great question. So there is uh, a study that actually looked at safe levels of walking, um, and found that people with severe osteoarthritis could tolerate walking. I think it was up to 60 minutes a week. So that is actually a bigger number than most people imagine. And it is important to talk about. Now, for the individual patient that has pain with every step they take, yes, certainly recommending a less painful activity like biking, recumbent biking, or biking, stationary biking, absolutely would make more sense, so that things aren't so painful. I also have to put in a plug for consulting with a physical therapist at this point and saying, helping them to understand where's their pain coming from. Is there modifiable things they can do in terms of stretching and strengthening to reduce that pain? Is another big option for people to. That's a resource that people with knee OA can use to help them become more active.
Great. So getting a personalized assessment and recommendation is important.
Absolutely.
Yep.
Yep.
Again, related question to walking, does the continuous walking duration matter for pain in knee OA?
Yeah, for some, and it is problematic because the physical activity guidelines are very specific with having 150 minutes of moderate intensity activity, and that is a big number for people to reach. Now, the good news is that there used to be a recommendation for that to occur in bouts lasting at least 10 minutes, and that recommendation has been since removed. So it doesn't matter how you total up to the 150 minutes, it can come from a little bit here and a little bit there. So for people that find themselves, not being able to walk more than 10, 15 minutes, doing them in sizable chunks is absolutely fine. I will say though, I don't think that that's usually the major problem that people have. The major problem people have is more related to getting started and having fear of hurting themselves while they walk. And, I think this is where having a resource with existing exercise programs that we have, such as the Walk with Ease program, is just a great way to help people get started, and and be encouraging, and being a really positive environment for people to get started.
It's great. And thinking about the bouts, that's just another way, or like spreading your walking sessions or activity sessions over the day is another way to reduce sedentary time. So it's another benefit of not doing it all at once.
Yep.
And one question here, if there are any other questions, please put them in the chat. I have one more that came in, and that's related to stretching, since that's recommended for adults with osteoarthritis. Does stretching count in your definition of physical activity, Dr. White?
Well, it definitely breaks up sedentary time. It probably does not going to, it's not going to count towards your moderate intensity time, because unless you're not going to burn many calories while you stretch.
Right. And maybe yoga, like a gentle yoga or something, could address both the
Yes,
stretching and the physical activity.
good point. So if you're getting into like holding different positions, now that could get into where you are stretching, because goodness, getting into a downward dog pose, or you're definitely stretching things, and you're definitely expending energy towards that moderate intensity. Yes, in that case, it could make an count towards guidelines. If you're stretching, more gently stretching, now that's likely not going to be at that moderate intensity. But again, that still, you're breaking sedentary time. And I do have to say, with the guidelines, one of the terms they use is, or recommendations they say is, some is good, more is better. So if it's enough to get off the couch and get moving, and if that's stretching, that is better than just than sitting there and not stretching.
That's right. And just want to let you know, if you're not looking at the chat, lots of comments here about thank you for the talk and great session. We did have a comment. Someone said that they ice and use a brace and walk 2 miles a day. So that's getting into kind of that treatment of, how to handle the pain so that you can be physically active, or if you're dealing with pain after the activity.
Yeah, and again, there's if people love to walk, you um, are able to manage the pain afterwards, I mean, that's fabulous. That is a very successful and effective way to continue to be physically active. And some days probably are going to be better than others, but having a plan to manage your pain and keep it under control it is fabulous. And again, partnering with a clinician to help you uh, come up with a plan if you need that is one way for people to get help.
Great advice. Well, we'll wrap it up there. I don't see any other questions in the chat. Thank you again, Dr. White, and thank you to everyone who attended today's presentation. I will be sending out a recording later this week so you can rewatch or share it with your friends and colleagues, so stay tuned for that. In just a moment, we'll launch a brief satisfaction poll. Hope you can answer those questions before you leave. And finally, we hope you will join us on October 16th for our next Lunch and Learn titled Empowering Adults with Osteoarthritis to Manage Their Fall Risk, which will feature Dr. Tiffany Schubert. And I'll put that link to the registration in the chat. Thank you again, and hope everyone has a wonderful rest of your day.
Thanks so much.